Hello everybody, my name's Lizzie Dodd. I'm the stroke nurse at the Royal Adelaide Hospital and a member of the Acute Stroke Nurse Education Network, ASNEN. Thank you very much for tuning in today for a very excellent talk by Jasmin Turner, our clinical psychologist. We are going to just do a little bit of housekeeping so you know where you are. And don't forget that all these sessions are recorded, so they can be watched at a later date. I'm going to hand over to Stacey Gorup for the kindly supported by Medtronic, who do all the technical stuff behind the scenes. Thank you, Stacey.
Hey, also I'll just go through the housekeeping slide that we have up here now. So to keep background noise to a minimum, all attendees have been placed on mute, as you probably would have seen thus far. If you have any questions, you can use the Q&A panel to ask your question at any time, and we'll pick it up and report that back to Jazz, who will answer them at the end of her lecture. There is also the chat function that is down there, which you can comment and chat amongst yourselves there, so utilize that as well. This event will also be recorded by ASNEN today and will be available in the future for future viewing. Also, if you have any feedback of any kind or any further questions or any events, topics that you would like to see, get in contact and give some feedback back to the ASNEN group. Other than that, over to you, Lizzie.
Thank you. Now, a lot of us are locked down in COVID. A lot of us are experiencing anxiety. I hope not depression, but of course, it's very evident in our patients. So Jasmin is one of the fantastic team based in South Australia, and we've been fortunate enough to have her at the Royal Adelaide. She's a senior clinical psychologist, and she's going to give us some excellent tips on how to look after our acute strokes who have anxiety, depression, and for those that we're going to palliate. Thank you, Jasmin, for your time today and for talking to us. Over to you.
Thank you, Lizzie, for inviting me to speak today. I'm really happy to have the opportunity. So as Lizzie mentioned, I'll be discussing stroke survivors and depression, anxiety, and palliation. Now, can I just check, should I be seeing a little version of myself? A little icon on the right. Can you see me if I show the presentation?
Yep, you can. So, yep, you can bring up the presentation now.
Cool. So, how's that?
Perfect.
Great. So I'm a senior clinical psychologist, and I'm currently working at Northeastern Community Mental Health Services. And this presentation is based on my prior employment with the Royal Adelaide Hospital. So I was working there for nearly 4 years on the acute stroke neurology unit. So this will be about the knowledge and experience I gained in that setting. So I wanted to just start with an acknowledgement of country. So as a non-Indigenous woman, I acknowledge the Kaurna people as the traditional custodians of the country that I'm speaking from, and pay my respects to the elders past, present, and emerging. Sovereignty has never been ceded. I acknowledge that Australia was founded on the genocide and dispossession of many First Nations people, and I support the ongoing struggles to maintain the colonial structures and policies that remain in place today and that will be affecting any of our Indigenous patients probably on an ongoing basis. So my work was on the acute stroke neuro ward at the Royal Adelaide Hospital. This is one of 3 acute stroke units in SA. While we were commissioned for 31 beds, we often had many more patients than that at one time throughout the hospital, and quite a busy ward, quite a fast-paced ward, and 120 patients through the ward per month. somewhat unusual for a psychologist to be doing such brief interventions. So a lot of our patients would be with us for between, even as short sometimes as 3 days through to a maximum of, in my experience, a few months, and quite a high proportion of patients from the country, as the tertiary service available to the population SA-wide with particular interventions, and also available in the evening. We also service the NT, so quite a variety of patients coming through. So I joined the team in 2017, and along with my then colleague, co-founded a dedicated clinical psychology service on the stroke ward. Prior to that, there'd not been dedicated psychologists, and the stroke unit had been serviced by psychologists across the entire hospital. And so this meant that we could see patients even with moderate needs, as opposed to really just the highest of risk being seen before that service. And we could sort of learn and tailor to the particular needs of stroke patients, especially with regards to things like aphasia and cognitive deficits. I think some psychologists, especially with aphasia, can be quite shy or inexperienced to work in that setting, because psychology is often a talk therapy. And so when someone is non-verbal, it can involve quite an adjustment to your work. So over the past number of years, there has been an increase in FTE of psychology across the acute stroke units in SA. The RA still holds the most psychologist FTE for the stroke unit, which is great. And I really love working on the multi-D team there, and it's often really described by so many different people across my time working there as a really tight-knit team, really supportive. The allied health team are really held in quite high regard. I've heard so many allied health comment on the respect that they're given, including by medical, for their opinions in that setting compared with other units. So that was really lovely to be a part of. So just to give a brief intro on the main topics I'm discussing. So I'm sure we've all seen many patients with depressive symptoms. So this is the criteria here. So I'll let you read through that, but I think some of the main things that I've noticed with this population is that, I don't know, I've heard some nurses say to me, all patients who have strokes get depressed. And I can't help but actually disagree. Having interviewed so many people with depression, without depression post-stroke, I think some people tell me I'm very depressed, I'm really upset. Some people say, I'm coping pretty well. I haven't had a change in mood. I was pretty scared at the time, but now I'm okay. There's a real spectrum of reactions and of mental health presentations in the days and weeks post-stroke that I found in that acute setting. Another thing that I've really noticed is that some patients, I guess they experience that adjustment to stroke. So it's really important to differentiate between a really natural adjustment to what's been a really big occurrence, having been through that potential trauma of not knowing what was happening, whether they were going to die. Some people are not sure, they thought they were going to die, going through with an ambulance, emergency services, ED. It can be a lot to go through. So for some people, I think it's very natural to have some of these symptoms, and for that to be non-clinical reaction, for it to just be a natural reaction. I'd be looking for these, you notice here there's a 2-week period that we have to have seen these symptoms for before we can diagnose. So we can certainly, before 2 weeks, post-stroke, acknowledge someone's at risk of developing this disorder, or maybe beginning to develop this disorder, but it's too early at that point to diagnose. pre 2 weeks. So, you know, I was quite cautious about diagnosing. You don't see a lot of my case notes saying I'm diagnosing MDD unless it was pre-admission. Another fairly common disorder that we see, nowhere near as common as depression, but it does happen to a proportion of our patients, is generalized anxiety symptoms or disorder. And this is that tendency to worry. It's people who may describe, I've always been a worrier, and difficulty controlling the worry. And it's not just about really understandable things, it's about a range of things. It's a tendency to have excessive anxiety and worry. I think these patients are at risk of heightened anxiety during times of stress, and they often do not cope very well with uncertainty. And a lot of the experience of having a stroke, I think inherent in that is the experience of uncertainty, which is anxiety provoking for all of us, probably especially so for people who already have anxious tendencies. You can tell who these patients are when there's almost an urgency to the treatment that they want, or they want to sometimes control their surroundings. You know, they might have somewhat increased speech rate, and you can tell they're anxious. That just a bit, like, often I'll have nurses say she's quite anxious, but you know, when you get there, you think, oh, it's quite long-term, quite chronic. I think the stroke experience really can involve a lot of uncertainty. People don't know how much they're going to improve by, how long it's going to take, what disability they may or may not be left with, what kind of treatment they'll need. Are they going to have to move later on? You know, it's a lot. And a lot of the time, the feedback that we get is that these patients don't always know the health system. And I think as professionals, we sometimes forget to communicate with them. And so often I was the one telling them, do you know what's coming next? What have you been told? And I would tell them a lot of what I did was just psychoeducation about the stroke journey, what was to come, and that was enough to alleviate a lot of the anxiety in these people. And yeah, I think we can't underestimate the benefit of sitting down, giving the patient time and asking, yeah, do you have questions? If they feel safe, they'll just ask, you know. And I think sometimes our patients have sometimes, you know, 8 doctors in a room on a ward. It's too much. They can't, maybe that's fine, but I mean, you know, even for a highly functioning person, that would be quite potentially intimidating, and not a setting where I'm going to feel really comfortable talking about my innermost vulnerabilities and anxieties. So I think sometimes, you know, as nurses, we can take that time to sit with the patient and ask them how they're feeling, and provide education about the future, which can reduce that uncertainty, and also normalizing. If you're not sure what the future holds, it's so understandable that you're feeling anxious. I think normalization, I would feel that way too. You know, a lot of people feel this way. Those messages can really help people to feel like what they're going through is normal. It just brings the intensity of that emotion down, and to validate how they feel. You know, you feel this way, I can understand, it's so normal. So I think that can reduce people's anxiety in the moment. So when it comes to palliation, the statistics that I've read are that about 30% of people who have had a stroke may die within that first year, and 5 to 20% in the first month. And obviously, in the immediate hours and days post-stroke, someone's at highest risk, and we're closely monitoring their survival, and you know, any complications that may be occurring. I think during this stage, if anyone's survival is in question, then it's important to really consider their future possible quality of life and their wishes, whether they can communicate them now, or if due to speech or cognitive ability, we need to think about prior wishes. These are really important considerations, and being client-centered during this time. If there is query palliation or like an unknown future for their life, for direction of care planning, important considerations. So why would you have a psychologist in this setting? I'm just going to check. I think I've got a, oh yeah, just checking the chat box there. So in our society, not considering strokes, in the broad society, depression is quite common. Anxiety is also relatively common. 1 in 5 women and 1 in 8 men in society will experience depression at some point in their lifetime. So I think it's important to acknowledge that, you know, stroke patients are at risk of developing depression, but people are already at risk just at large, and a lot of societal factors affect that. You know, we should take these conditions really seriously and treat them as needed. I think depression and anxiety, mental health issues can really affect someone's functional recovery from stroke. It can affect their motivation. If they can't concentrate because they're depressed, that can affect the information that they receive. It can affect their engagement with allied health interventions and rehab. You know, anxiety of fear of falling after having a fall post-stroke can affect their engagement with PT and walking. You know, it can really affect a lot of the different ways that they are functioning throughout every day. So the more we can support someone's mental health and the earlier we can detect and treat, the better chance someone has of recovering from their stroke quicker and engaging in that rehab opportunity. So I think, you know, post-stroke, I've read that there's a window of improvement where someone has the most, or the research shows that people show the most improvement in the first 3 to 6 months. So I'm not afraid to tell patients who are not engaging as well as we might hope in rehab and intervention, to let them know, like, this is an important time opportunity for you to engage in this rehab. This is an opportunity. You're in a public setting, you can get the treatment for free, and just to really encourage that engagement. If someone's depressed because they're not motivated, often there's a really strong urge to just stay in bed, and that's for people who haven't had a stroke too. You know, the will to get out of bed and engage can really be, you know, coming in strong. People talk about that dark cloud. So whatever we can do to encourage engagement and get out of that will help someone to maintain staying out of that. And we want them to just appreciate that this is a time when we can really maximise their improvement, and this may have long-term consequences. So I guess these are some ways that we might be able to tell someone might be depressed on the unit, or in any health setting. So there might be clues as to someone's risk for mental health issues in a handover, having prior mental health issues, seeing a psychologist or a psychiatrist or a social worker or a counsellor, being on antidepressants or anti-anxiolytics. Family members sometimes tell us. Obviously, observation nurses have such an important role to play. You spend the most time with people. You often have really unique observations about how they're going, or they might confide in you more than someone else or another professional. We can use screening tools like questionnaires, and all those symptoms of depression, sleep, appetite, irritability sometimes, concentration, motivation. If we see reductions or changes in these, it can be an indicator. Once we had a patient who wasn't eating, and they weren't on my radar, and the dietitian couldn't figure it out, neither could the doctor. And in one meeting I sort of said, could it be depression? Because no one could figure it out. And they went and asked them later that day, he appeared fine. And yeah, he had been having some mood disturbance, but he was an older man. I think he had some internalized stigma around mental health, which is not at all uncommon. And they think that that may have been what was contributing to his appetite reduction. And that was really important for placing him on antidepressants that might help stimulate appetite as well, and referring to mental health post-discharge. This is an example of a questionnaire you can use as a screening tool. I haven't yet found a screening tool that I really love for people with aphasia particularly, but there are a few options. In the hospital setting, if you don't have a psychologist, the PHQ 4 or 9 can be good options, but they are for people who don't have aphasia. So when I'm receiving a referral, or if you're thinking of making a referral to a psychologist or therapist, these are some questions that you might want to think about before you come to that person. Just checking a question here. So thank you, Susie. I've got that question. So I'd be thinking about how many days post-stroke is this person. So if they're in the first few days, I probably would be saying, if there's no other depression symptoms, if there's no prior history of depression, then maybe wait and see. Maybe a social worker could see them for some grief counselling. It's very normal that they're feeling upset so close to the stroke. Let's wait and see. And if after sort of 3, 4, 5 days, they're still showing signs of feeling depressed or crying, then I might begin to start working with them. If I had all the time, I'd be happy to see everyone, but I have a busy caseload when I'm there. So just thinking about what's behind the referral. Sometimes it might be just one small thing. It might be important to monitor what kinds of symptoms they're experiencing, what's their participation, what meds are they on, what's their prognosis. What are you hoping I can achieve? Importantly, when's their discharge? If they're going to discharge soon, then I'll increase the referral. And sometimes I'll ask my colleagues, like, how urgent do you see this referral as being? Like, I've got this person on this, but which do you see this as being higher? Like, I'll try to collaborate with the referrer around this.
So Jas, I'll just interrupt for one. For those of you that didn't or can't see the question that was asked was, with an acute stroke patient, when is the right time to do the first screening for anxiety and depression?
Yeah, exactly. So we've had a lot of discussion about this, and it's a really good question. It's not an easy one to answer. I think we kind of came up with around 1 week as a good time to let someone kind of settle into the situation if they're still in hospital. Some strokes, particularly hemorrhagic, it can take some time to even just be, sort of over that initial really heavy sleeping, and you can see rapid improvement in some people over the course of a few days. So that, I think, gives them time to sort of recover a little bit and get a sense of what's going on, and then adjust and react, and then you'll start to see what their reaction is. So for me, that's kind of a good time if you're looking for a general ballpark. And I think mass screening of a whole unit is very reasonable if you have the capacity. Also, I think it's good to screen if you suspect someone might be at risk of depression symptoms or anxiety symptoms. If they have a current diagnosis, that's we already know that, but I guess screening can tell us a little bit more, and then that's just a screener. So then you can do more detailed assessments with obviously clinical interview or psychometric screening with questionnaires. I'll just check what this next question says. Yeah, look, the stroke. Yeah, so Susie's commented again. The Stroke Foundation guidelines state that the patient is screened with an assessment tool. The Stroke Foundation guidelines, when I last looked at them, was about probably 6 months ago, and I have communicated a bit with Stroke Foundation around their own guidelines for screening. They recommend that they encourage patients to be screened. In the past, they recommended every patient be screened. I think it's a real cost-benefit analysis. For me, I was always busy with patients who undoubtedly had like disorders or would benefit from psychology. The team brought me patients who they felt had mental health issues. So I felt that for me to engage in screening and documenting, 40 patients at a time sometimes, and then a large number of those probably wouldn't have mental health issues, may not be the best way to spend my time. A lot of units are doing it, and I think that's fantastic. I would encourage it where possible, but I think it just is resource specific and independent. I think just reading this next comment. So Tanya's written, with a short length of stay, how do we go around this? I find patients calling me weeks later to talk, and I discover their anxiety and depression at this time. I refer to GP and mental health care plan, yet this seems inadequate. Is there something else I can do? Yeah, I think if you don't have a psychologist or a therapist on the ward, or even if you do, if you have the capacity to do screening, then that can begin the conversation when they're in front of you. So I think that would be probably, if you have the ability, just go for it. If you have any, I think, day one's too much. They're too busy. I always think that these poor patients, they just get pummeled with assessments the first few days. They're exhausted, and they're already exhausted because of the stroke, which has the heavy symptoms of fatigue and, drowsiness initially. So I always leave them alone for the first 2 days, unless I'm being called in quite urgently. And then after that, you could just, if you think. And then Tanya agrees. Yeah, I know GP is not great. Stroke Foundation offers a really wonderful counselling service. There's other telephone counselling options. I mentioned later, sometimes there's support groups. In SA, we have a choir at a rehab setting that we work with. Sometimes we send patients there with aphasia, and they can, but they're pretty open. People without aphasia can go and join in information sessions with shared experience. And also the Enable Me community is quite supportive, I think, for sharing amongst patients who have been through this. So it's a huge network, and it's pretty amazing, the sense of connection and understanding people can find online. And I think that Stroke Foundation's done a great job of making that website quite user-friendly for patients who may have vision issues or other accessibility issues. I wish mental health had more funding in our country. Private psychology, it's a long wait list right now, especially with COVID. So unfortunately, often that is the best option. Yeah. Okay, so you've had this screen for a while. So first of all, I would often ask doctors to run an initial Jerry blood screen. I want them to check for things like low iron, thyroid issues, B12, anything that could cause low energy, which can affect motivation. And that's best practice to check physical causes for depression symptoms in any setting. A lot of these older patients may have low vitamin D. Iron is an issue for especially women. And so if we can just get them screened and then treated for any deficiencies, that can help. This is the approach I take. An important thing to note is emotional lability. This can be another overlap of the symptoms. So someone who's had a stroke can experience pseudobulbar affect or emotional lability, for an easier way of wording it. And this is just that emotional dysregulation that can be a result of the changes in the brain as a result of the stroke. And so people won't, that's not a very well-known occurrence, even amongst health professionals, let alone society. And so people might not know why they're crying a lot, and they might think that it's a representation of their mental health, and it can be, but sometimes it's separate. Sometimes someone, is crying and they'll tell you, I don't know why I'm crying, there's nothing wrong, or I'm not upset. And so when you learn that there's an incongruency between their emotions and their behavioural display of distress or even laughter, or any emotion, that can be a clue, or you can just ask outright that there's emotional lability going on. And that can, it can just involve like more intense emotions. So someone might laugh or cry at inappropriate moments, or a small sad thing like a puppy dog on TV, can set people off crying, and they'll say, I don't know what's going on. It's a bit disconcerting. And I've heard some patients say, I've just got such a lack of control over even my emotions now. So yeah, that can be quite challenging. In this instance, I'd say like distraction, normalization, moving on, and educating anyone who's new to the person can be the best way to respond. It's not if someone was crying due to grief, I would encourage them to just let yourself cry, let it out, I'm here, there's no rush, that kind of thing. With emotional lability, it's not a genuine expression of emotion. It's an inappropriate expression of emotion, even that they don't want. So I wouldn't engage with it too much. Yeah, I've mentioned that, it's really understandable to be upset post-stroke. So sometimes someone's normal adjustment to a stroke may look similar to depression. And with time, I think you can really begin to tease out whether this is a clinical presentation of depression or if it's more a really natural reaction. If I had a stroke, you can bet I would be crying. It's very stressful. So it's too early to say in the first half a week, I'd say, whether someone's at risk of depression or not as a direct result of the stroke. So for like a clinical psychologist, these are some of the things that I engage in with my treatment. And one that I think that, like, some of these are things that anyone can do, and some of them are more specific to psychology. I mean, I think there's a movement toward nurses being trained in things like cognitive behavioural therapy, motivational interviewing. I know a lot of health professionals of a lot of different disciplines are trained in. Applied relaxation, which I'll go more into, anyone can give resources on and teach. Psychoeducation, teaching people about the stroke journey, that what I mentioned about emotional lability. Lifestyle education about things like diet, exercise, sleep, problem solving, communicating, letting your emotions out. All these things can be beneficial for well-being. Telling about the stroke journey and what to expect can be useful for helping someone understand what's going on, which early on a lot of people do say we haven't been talked to, or they forget, and that's very natural for them to forget. I think giving hope for the future. I think strokes can, something that's nice about strokes is that once, putting aside health complications or palliation or other conditions that suddenly arrive, time and rehab come together to really support. Like, everyone I've ever met improves in some way, even if it's minuscule, and a lot of people see a lot of improvement. So really giving hope that we will see some improvement, we just don't know how much or how long. And again, that validation and normalization, that's basically a form of therapy. It's supportive psychotherapy to really say, like, how you feel is so understandable. It's good you're talking to me, you know, I'm here for you, like providing that support. A lot of people on this unit have been through the same thing as you. You're not alone. Those kinds of messages can be really validating for people who are feeling quite overwhelmed and upset. So behavioural activation is something that we can do with patients on the ward. It's a very common treatment for depression. It's something that also can be delivered to people who have communication issues and even cognitive issues. And it really just involves increasing the amount of activity someone does in a day. So structuring their day with different activities, allowing for rest, and then them engaging in that can help lift them out of a depression. And doing so sort of gets them out of the habit of not doing much, and it sort of, yeah, encourages that positive cycle of, you know, you feel good because you achieved something, then you feel motivated because you're in the rhythm. And I think we've all experienced that, like getting back to the gym, you know, once you're in that habit, you sort of stick at it. These are SMART goals. Anyone can sort of talk these through with a patient. Sorry, here's the SMART goals. Yeah, so just looking for simple, achievable steps, making them really clear, celebrating the wins. You know, daily little goals for bigger goals can be really useful to give someone sight of what's to come and what they're aiming toward. I might just move through. So this is applied relaxation. So using the belly to breathe is really useful. I think a lot of people chest breathe, especially when they're stressed and anxious and they're going through a hard time. People who are naturally anxious or have a history of mental health issues are more likely to be chest breathers. We really want to encourage belly breathing, and guiding someone through that and modeling it yourself is a really effective way of teaching someone how to do belly breathing. Another technique is to ask them to lay on the ground where they already are, putting a book on their belly and making the book go up and down as they breathe. So if you all just want to try this right now using this image, this can be a really lovely guide. And if we count breathing, patients get a bit overwhelmed. But having this guide, which is actually it's asking you to do quite a long breathe in and out, it feels quite manageable, even for people who have really quite shallow breathing. And if people can practice this kind of breathing every day, the theory is that practiced deep breathing actually does bring down their physiological arousal. It helps manage stress, and if this is practiced for long enough, it does have a really important impact on depression and anxiety. This is a very specific kind of progressive muscle relaxation is shown to be useful for anxiety, helping people get to sleep. If it can be done even with people who have hemiplegia. And it really involves clenching and then releasing different parts of the body, you know, breathing in and then squeezing, holding your breath, squeeze for 5 seconds, release and breathe out, and really relax that body part for 10 seconds, always double the length of time for the tense, and notice how your clenched hand or body part, how different it is when it's released. It's easier to relax from a place of tension often. And then you just go through the whole body one by one. We can all benefit from relaxation. It should be taught in schools. It's ridiculous that it's not. And it's more than just relaxing, you know, watching TV or chatting. You know, you can have active, intentional forms of relaxation that can be really effective for managing depression and anxiety symptoms. These are some fantastic guides. CCI, Centre for Clinical Interventions, is a website. Just Google it. It's a Perth-based organisation, and they have a million different workbooks. It's fantastic. They've got one for depression, one for anxiety, like different forms of all kinds of mental health issues. These two specific ones work on 2 different types of relaxation strategies, and they're very clear guides. They can be useful for both clients, but also for workers and for yourselves. This lady on the left here, Yoga with Adrian, can't recommend her enough. She's this great yoga teacher on YouTube. She's so sweet. She's American and very down to earth. And she's got some chair yoga. She's got some that's just for neck and shoulders. So for patients who have limited mobility, there's a bit more options there. This is a really lovely album. It's just got very beautiful meditation music. And there's so many options online for guided relaxation. Insight Timer is an app that I often use myself and recommend. Sarah Blondin is a really lovely speaker on there, but it's got thousands and thousands of guided meditations and for specific, you know, whether it's depression or, you know, for gratitude or all kinds of different topics. I think, you know, at the Royal Adelaide, we pride ourselves on single rooms, which is good, but sometimes I think there's limited opportunity for activities or shared experience. So I really encourage varying the environment where possible. It can be very boring to stay in the one room. It costs money to use the TV, which is ridiculous in my opinion. If someone has had a stroke, they can't always read properly. They might have vision, concentration issues. You know, there's limited options. So I think doing things to change their environment can help them feel happier, and there's more purpose to a day. So these are some options. I think, you know, making the environment warm and less clinical can be helpful for someone's mood and sense of being at home and well-being. I love to have natural lights too. Often I have patients lying in bed and they're looking straight up into a horrible blue, bright fluorescent. It's just awful. So I always ask patients, I always offer to turn off the lights, have the nice warm backlight, open the windows. Sunlight's good for the circadian rhythm. Yeah, offering options. You know, sometimes patients don't even have a phone. They've got nothing to do all day. So, you know, just watching out for that. If there's any group activities, that can be really useful. Communal meals are great for that connection option. These are some referral options we've got at our hospital. There might be others, you know, at different places that can be really useful. I'd often collaborate with these different kinds of professionals about how we could improve someone's, you know, well-being and sense of support and connection and community. But yeah, something to just point out there though is that sometimes patients really cannot cope with a lot of stimulation compared to before. Watching the TV can be too much. Hearing 2 people talk at the same time can be incredibly irritating for a patient, when usually they would have been fine before that. And that's simply a stroke symptom. Once I think I was referred a patient in rehab who there was query depression. And once I talked to her, I really just felt this is just overstimulation. She just needs to be, you know, in predictable environments that are time limited, people checking in if she needs a rest, even exploring earmuffs or earplugs. Is there too much family visiting? People need to recuperate. I think meditation, brain relaxation can be useful for maximizing the potential for neuroplasticity to take place. And I think I cannot stress enough how important this client-centered treatment can be. These patients are often very dependent and they've never have been before, and they're quite vulnerable. You know, some of them are very high functioning and it won't be so much change for them, but a lot of the time people talk to me about, you know, really hating being incontinent and being just so mortified by the fact that they're not able to control themselves like they used to. and people not coming quickly to change them because of understaffing, and there's a real impact there on mental health. I think things like mouth care, it's so important to have that these patients have the support to have, you know, what they would usually engage in as possible, offered to them. If they can be offered choices, that can be a really good thing. Sometimes patients, I think, have even talked about, like, I just feel like they don't see me as a person, but they're just at work. And, you know, one woman who I think, you know, she had a lot going on, so I take her communication with a pinch of salt, but she talked about, I just feel like I'm a piece of meat being rolled around, which is, you know, my heart broke for her. I just, you know, always treating people like that person that they are. And I'm sure all of you you know, are motivated, and that's why you're in this group. But I think that, you know, if someone around you is not, you know, calling them out or encouraging that client-centered approach, can be really important for maintaining and supporting someone's well-being and their experience of the service. Now, I'm not sure, how are we going for time? I've got a video here I can show, but and I've also got a chat here. Oh yeah.
Guys, we're okay. It's 2:15. We've got till 2:30. So I think you can play your video.
Okay. This is a girl named Sarah Scott. I love her and her mum. They live in England. They're so sweet, and every year they do an update, and she has aphasia. She's 19 when she had her stroke. Just let you see her a bit.
Hey Jazz, is there any volume?
Any volume?
Yeah.
Oh, sorry, you can't see it? You can't hear it?
No, so you need to optimize for videos. So when you're sharing the video, change your video settings to optimize for video.
Okay, how's this?
So what's your name?
Perfect.
Scott. Oh, no. Sarah Scott.
That's right. And how old are you?
I can't.
Try.
I can't.
Oh. You're 19. 19. Yeah. And what happened to you?
So she had this stroke, and you can see there, I think it's really interesting to note, I'll just make, that a bit of tension there between her and her mum who's recording. And, you know, I think it's good to bear in mind, you know, families of stroke survivors, they're under a great amount of pressure too. And sometimes when people are more dependent than usual, they can be a bit snappy, or you can see that in them. Her mum's so beautiful and supportive. And it's, obviously she has quite a profound aphasia there. Now let me just move on. Yeah, so this is her 6 years later. I'll just give you a really quick show of that.
Doing now first. So I'm working at a school. The school that I actually went there, and the school that I had my stroke at. So yeah, I really like it there. The people there know about my disability, so the people are really nice and friendly. And
yeah, I just love them. They're very engaging. They've done a lot of advocacy about strokes, aphasia. They've started a support group where they live in England. And you can see there she's made so much improvement, but she's had a lot of speech therapy, and she's working part-time. You know, you can hear there she references her own disability, and she's come to terms with that over time. So yeah, I think I always watch their updates, and it's really lovely.
Understanding.
Now, I think we're going to run out of time for palliation discussion. I think, I think when people have a stroke, it's a massive life event for them, and it has huge impact on them and their people who surround them. And our patients remember their time in hospital, and they remember, the care that they received. And we can be really important people during such a difficult time in their lives. And I think we can really make a difference with those acts of kindness and supporting people who are vulnerable to developing mental health issues due to structural changes in the brain because of the stroke, or adjustment issues to what the stroke means for them and the changes that it causes in their life. And I just really encourage self-care, because it's a challenging area to work in. These people are having a rough time. It's heavy work. And so I just would encourage, looking after yourself, looking after your team. If we encourage people to engage in self-care and relaxation, trying to do a bit of that ourselves, so we can say we've done it, it works, or this is what I found. Recognizing our good work, celebrating our wins, they can be really useful as well. And this is how you can get in contact with me. And these are some references. So I'm happy to answer any questions that you might have. So I've just got a question here from someone.
Go ahead, Jess.
So Maxine, can everyone read that? So
no,
Maxine,
they won't be able to read it.
Maxine says, I work in Wellington Hospital, New Zealand, and we have a policy which suggests depression screen on all patients within 6
weeks.
6
weeks
of stroke, unless deemed more urgent. So usually we screen patients in the community post-discharge. That's fine. I think, my experience is in that acute setting. I think though, 6 weeks, 6 weeks is fine. 1 week's fine. Whenever, 1 year later is still good. It's important to always screen for mental health, I think. If GPs had more time, it'd be great if they asked everyone that they see. I think the reason why it's good to know early on is so that we can engage in early intervention. And also, it's not like I'm not able to prescribe medication, but I can encourage doctors or psychiatrists to consider certain medications. And there's certainly, medications for mental health issues can be controversial, but I think in the area of stroke, there's sort of a lower threshold for considering treating someone psychotropically, because stroke patients are at such high risk of developing mental health issues. And in some people, it's difficult to tease out what's been structurally caused depression, because some strokes do place someone at greater risk due to the area of the brain that's been affected. But for the majority, it's adjustment related. So, I had one colleague tell me she went to a seminar on stroke management, and the doctors said some people are proponents of giving everyone antidepressants who have had a stroke, which I think is too much. But I think that early intervention is important, and also antidepressants can take 4 to 6 weeks to reach full efficacy, which is a long time. So also some medications like mirtazapine, for example, aids people in sleeping well and increasing their appetite. It can risk though a small amount of weight gain. So if patients, as long as they know that if they gain a huge appetite, to be careful what they actually eat despite that increased appetite, to not gain weight excessively. But that can be a useful one, particularly with sleep issues, which are not at all uncommon. or, you know, other common ones that we prescribe are sertraline, escitalopram, which are that activating, you know, can help with things like motivation. So, you know, we want to maximise that window post-stroke of recovery and allow people the most opportunity to engage in their rehab and have their brain recover. So, so that's why we would encourage earlier on screening. The other thing is some patients present very well, but they are masking their symptoms. So some people, you know, it's quite surprising that when you actually interview them, they tell you, oh, I mean, one guy I've diagnosed with depression for the past 2 years since he retired, but he came across, and one of the doctors said to me, he's not depressed. And I was like, excuse me, I've done an entire psychosocial interview with psychometric screening, got collateral from the wife. I'm pretty sure he's, you know, I was certain, you know, like these people can present very well. And it's so common that, you know, all of us would have colleagues at the very least who are depressed and on antidepressants, and yet are very high functioning, and you'd never know the difference. So we can't kind of assume that just because someone's presenting well, that they're not having a very different experience internally. I think, though, it's fair to say that the more severely depressed someone is, the more likely they are to show those behavioural signs. But yeah, someone can be quite severely depressed and we won't know it. So that's another reason to screen. Yeah. Are there any other questions?
I haven't seen any more come through. Thank you, Jasmin, for a lovely talk. I liked your many of your pictures, especially the patient with the on the bars with the bottom hanging out. We see far too many of those, perhaps. And that's a great pointer, is to get up, get dressed, get your dignity. It must help with your mental health. And I was doing my breathing exercises, and you know, it is very calming, and little things like that can make a big difference.
Oh my gosh, yeah,
thanks
so
for those.
true.
There's a couple of another question here. What other validated tools can we use to screen for anxiety and depression? So
yeah, what I might do, is just, have I stopped screen sharing?
No, you're good.
Yeah, I have. I can go and check.
Perhaps we can add them as a slide to the end of the talk for where people can get them, because they'll be able to have a look and see what might fit their hospital circumstance. I think it is very undecided as to when is the best time to do a stroke and anxiety depression scale assessment. But
yeah, I actually asked the Stroke Foundation, I talked to them and said, which ones do you recommend? And they didn't have a good answer. They asked me, what do you recommend? Like,
well, indeed.
So
maybe we can put up some suggestions, like you had the one you devised for us at the Royal Adelaide. So, you know, we can actually add that to the end of the slide, and then it's there for everybody. The talk will be up on the ASNEN website. Please do access it, and there you'll be able to see other ASNEN topics that you might like to revisit. We have an excellent talk last time from a young stroke survivor and her mum, who's a nurse, to revisit those. So there's lots of help and support there with your ongoing education. So I think we need to call it a day now. Thank you, Jasmin. I appreciate that. What are you showing us now?
This is a document that we've developed that's just yes/no questions, so that someone with aphasia can just nod or shake their head if you know that they've got fairly reliable like yes/no responses, which a speech path can tell you. So, you know, you just ask these questions straight out, whereas as a psychologist, or even a lot of health professionals, we're used to asking open questions like, how are you feeling? And someone without that verbal ability cannot answer that. So we have to aid them. So this is just a nice kind of, it's not a screening validated tool, but it is a way of asking those screening questions for a clinical interview. And really that will give you a lot of information, I think. Yeah.
Okay.
Thank you.
Thank you very much. Look out for the ASNEN emails coming through. So we have a major incident going on at the Royal Adelaide, so apologise for our overheads, but we'll look out for your emails and for the next talk coming up in September. Thank you all.
Thank you for having me.